Sarcoidosis is a systemic inflammatory disease characterized by the formation of non-caseating granulomas in various organs, most commonly affecting the lungs, lymph nodes, eyes, and skin. While the exact cause is unknown, it is believed to result from an abnormal immune response, possibly triggered by environmental factors in genetically predisposed individuals. Pathophysiology. Granulomas are clusters of immune cells that form in response to an antigen. In sarcoidosis, these granulomas do not break down as they should and accumulate, leading to inflammation and tissue damage. Epidemiology. Prevalence. Sarcoidosis affects individuals worldwide, with higher rates in Northern Europe and African American populations. Gender and age. It typically affects adults between the ages of 20 and 40, with women slightly more prone to the condition. Clinical features. 1. Pulmonary involvement. Most common, nearly 90% of patients have lung involvement. Symptoms include cough, dyspnea, and chest pain. Imaging, chest X-ray CT, may reveal bilateral hilar lymphadenopathy or interstitial lung disease. 2. Lymphadenopathy, enlarged lymph nodes, particularly in the mediastinal and peripheral regions. 3. Ocular manifestations. Uveitis is the most common eye condition, which can lead to visual impairment if untreated. 4. Skin involvement. Skin lesions, including erythema nodosum, tender red nodules, lupus pernio, chronic violaceous skin lesions, and plaques. 5. Cardiac involvement. Infiltration of the heart can lead to arrhythmias, heart block, or cardiomyopathy. 6. Neurological involvement. Neurosarcoidosis can affect the cranial nerves, leading to facial palsy or other neurological deficits. 7. Other organs. Sarcoidosis can involve the liver, spleen, kidneys, and joints. Diagnosis, histology. Biopsy of affected tissues reveals non-caseating granulomas. Imaging, chest X-ray, CT, MRI, depending on organ involvement. Lab tests, elevated serum angiotensin converting enzyme, ACE levels, hypercalcemia, and elevated inflammatory markers. Pulmonary function tests may show restrictive lung disease. Differential diagnosis, granulomatous infections, e.g. tuberculosis, lymphoma, hypersensitivity pneumonitis, autoimmune diseases, e.g. lupus, rheumatoid arthritis. Treatment, observation, asymptomatic cases or mild disease may resolve spontaneously without treatment. Corticosteroids, mainstay treatment for symptomatic cases. Prednisone is commonly used. Immunosuppressive agents, methotrexate, azathioprine, and TNF inhibitors may be used in steroid-refractory cases. Organ-specific care. Cardiac sarcoidosis may require pacemaker or defibrillator placement, while neurosarcoidosis may need tailored neurological care. Prognosis. The course of sarcoidosis is variable. Some patients experience spontaneous remission, while others develop chronic disease leading to organ damage. Lung fibrosis and chronic pulmonary disease are common complications. Regular follow-up is essential to monitor disease progression and adjust treatment accordingly. The classification criteria for sarcoidosis are not fully standardized like some other autoimmune diseases, but diagnosis is typically based on a combination of clinical, radiologic, and histologic findings. Several proposed criteria and methods help in diagnosing and classifying sarcoidosis, but these serve more as diagnostic guidelines rather than formal classification criteria. General diagnostic approach. Classification criteria. 1. Clinical presentation. Presence of characteristic symptoms such as cough, dyspnea, skin lesions, or ocular manifestations. Systemic involvement, e.g. lungs, skin, eyes, heart, liver, nervous system. 2. Radiographic findings. Stage 1, bilateral hilar lymphadenopathy, BHL, without pulmonary infiltrates. Stage 2, BHL with pulmonary infiltrates. Stage 3, pulmonary infiltrates without BHL. Stage 4, pulmonary fibrosis. 3. Histopathologic evidence, non-caseating granulomas in biopsy specimens from involved organs, e.g. lung, lymph nodes, skin. It's critical to exclude other causes of granulomatous disease, e.g. tuberculosis, fungal infections, malignancies. 4. Exclusion of other granulomatous diseases. Rule out infections like tuberculosis, fungal infections, e.g. histoplasmosis, and other granulomatous conditions such as berylliosis or lymphoma. 5. Supportive laboratory tests. Elevated serum ACE, angiotensin-converting enzyme levels. Hypercalcemia or hypercalciuria due to increased vitamin D production by granulomas. Liver function tests may show abnormalities in liver involvement. Elevated inflammatory markers, e.g., ESR, CRP. 6. Pulmonary function tests, PFTs, may show restrictive lung disease, reduced lung volumes, or obstructive patterns depending on the extent of lung involvement. Scatting criteria, radiographic staging. This classification is used to stage pulmonary involvement in sarcoidosis based on chest X-ray findings. Stage 0, normal chest X-ray. Stage 1, bilateral healer lymphadenopathy, BHL alone. Stage 2, BHL with pulmonary infiltrates. Stage 3, pulmonary infiltrates without BHL. Stage 4, pulmonary fibrosis. WASOC Sarcoidosis Organ Assessment Tool for clinical research purposes. The World Association of Sarcoidosis and Other Granulomatous Disorders, (ASAG), developed an organ assessment tool that helps clinicians systematically classify organ involvement. This is primarily used for clinical research and trial purposes. TARD ACE risk model, sarcoidosis-related mortality risk. The ACE risk model helps classify sarcoidosis patients into risk groups based on factors like age, race, sex, and extent of disease, pulmonary and extrapulmonary. This model is less about classification and more about predicting disease course and mortality. Diagnosis versus classification. Diagnosis requires clinical judgment based on organ involvement, imaging, biopsy, and exclusion of other conditions. Classification. The aforementioned radiologic, histologic, and laboratory findings help categorize patients based on disease severity, e.g. pulmonary versus multi-system involvement. In practice, the diagnosis and classification of sarcoidosis rely on a combination of clinical criteria, imaging, and biopsy, while excluding other granulomatous diseases. The most recent guidelines for the diagnosis and treatment of sarcoidosis are provided by various organizations like the American Thoracic Society, ATS, the European Respiratory Society, ERS, and the World Association of Sarcoidosis and Other Granulomatous Disorders, WASOG. The updated guidelines emphasize a multidisciplinary approach, as sarcoidosis is a multisystem disease. Updated guidelines for diagnosis of sarcoidosis. 1. Clinical evaluation. Multi-system involvement. Sarcoidosis typically affects multiple organs, but 90% of cases have lung involvement. Symptoms. Patients may present with nonspecific symptoms, cough, dyspnea, chest pain, fatigue, or organ-specific symptoms, e.g. eye pain, skin lesions, heart arrhythmias. 2. Imaging. Chest X-ray remains a first-line tool for detecting bilateral healer lymphadenopathy and parenchymal lung disease. High-resolution CT. Recommended for better characterization of pulmonary involvement. It's more sensitive in identifying early lung changes, such as fibrosis, ground glass opacities, and small nodules. PET-CT scan may be used to assess active inflammation and determine the extent of systemic involvement, particularly in cases where standard imaging and biopsy are inconclusive. 3. Biopsy and histopathology. Biopsy of affected organs, e.g. lung, lymph nodes, skin, showing non-caseating granulomas, remains a cornerstone for diagnosis. Transbronchial lung biopsy, TBB, or endobronchial ultrasound-guided needle aspiration, EBUS, are minimally invasive and increasingly used to obtain tissue from mediastinal lymph nodes. Exclusion of other granulomatous diseases, e.g. tuberculosis, fungal infections, lymphoma, is critical before diagnosing sarcoidosis. 4. Laboratory tests. Serum ACE levels. Though nonspecific, elevated levels of angiotensin-converting enzyme, ACE, can support diagnosis, especially when consistent with clinical and radiologic findings. Calcium metabolism. Monitoring for hypercalcemia or hypercalciuria due to increased production of vitamin D by granulomas. Inflammatory markers. Elevated C-reactive protein, CRP, or erythrocyte sedimentation rate, ESR, may indicate systemic inflammation. 5. Pulmonary function testing, PFTs, recommended for evaluating lung involvement. PFTs may reveal restrictive or obstructive patterns and decreased diffusing capacity of carbon monoxide, DLCO. 6. Cardiac screening, ECG and echocardiogram for all sarcoidosis patients to rule out cardiac involvement. Cardiac MRI or PET scan should be used in symptomatic patients or if other tests suggest cardiac sarcoidosis. 7. Ocular screening. Annual eye examination is recommended even for asymptomatic patients, as sarcoidosis can cause uveitis, which may be silent. Updated guidelines for treatment of sarcoidosis. The management of sarcoidosis depends on the severity of the disease, organ involvement, and patient symptoms. Many cases resolve spontaneously, and treatment is only required for symptomatic or progressive disease. 1. Observation, watchful waiting. Asymptomatic or mildly symptomatic patients may not require treatment and should be monitored, as sarcoidosis can resolve spontaneously. 2. Corticosteroids, first-line therapy. Prednisone remains the cornerstone of therapy for symptomatic sarcoidosis. Initial dose, 20 to 40 milligrams per day for pulmonary involvement. Gradual tapering is recommended after 3 to 6 months to minimize long-term side effects. Duration. Therapy usually continues for 12 to 24 months, though some patients may need long-term therapy. 3. Steroid-sparing agents. For long-term therapy, methotrexate, the most commonly used steroid-sparing agent, typically given at 10 to 25 milligrams per week. Azathioprine, an alternative, especially in patients intolerant to methotrexate. Leflunomide, used less frequently but can be an option. Mycophenolate mofetil, an option for neurosarcoidosis and other severe cases. 4. Biologic therapy, TNF-alpha inhibitors, infliximab and adalimumab, indicated in refractory or severe cases, especially those involving the lungs, heart, or central nervous system. They are considered for patients unresponsive to corticosteroids and immunosuppressants. 5. Organ-specific treatment, pulmonary sarcoidosis. Steroids remain the first-line treatment. TNF inhibitors may be required in refractory cases. Cardiac sarcoidosis requires aggressive treatment, typically with corticosteroids and immunosuppressants. Cardiac arrhythmias may require the use of pacemakers or implantable defibrillators. Neurosarcoidosis, typically treated with high-dose steroids, often combined with immunosuppressants like methotrexate or azathioprine. Ocular sarcoidosis, topical steroids or systemic corticosteroids depending on severity. 6. Adjunctive therapies, antimalarial drugs, hydroxychloroquine, used for skin lesions, hypercalcemia, and some cases of pulmonary sarcoidosis. Thalidomide can be considered in treatment-resistant skin lesions. Anti-hypercalcemic treatments. If hypercalcemia is present, patients may require treatment with agents like bisphosphonates. 7. Pulmonary rehabilitation, recommended for patients with persistent dyspnea, even if their lung function is stable. 8. Lung transplantation, considered in cases of end-stage pulmonary fibrosis unresponsive to medical treatment. Monitoring and follow-up. Regular follow-up is necessary to monitor disease progression, treatment response, and potential side effects of therapy. Patients with pulmonary involvement should undergo regular PFTs and imaging. Those with cardiac involvement need continuous monitoring with ECGs, Holter monitors, or cardiac MRIs. The latest guidelines emphasize individualized treatment based on organ involvement and severity, with close monitoring to avoid overtreatment or undertreatment. Differentiating sarcoidosis from other conditions is essential, as many diseases can present with similar clinical, radiological, and histopathological features, particularly granulomatous diseases. A thorough differential diagnosis is crucial to avoid misdiagnosis and improper treatment. Below are the major conditions to consider when distinguishing sarcoidosis. 1. Infectious granulomasis, TB. Similarities. Both sarcoidosis and TB can present with pulmonary infiltrates, lymphadenopathy, and granulomas on biopsy. Differences. Granulomas, TB granulomas typically show caseating necrosis, while sarcoid granulomas are non-caseating. Microbiologic testing. TB can be confirmed through positive sputum cultures, PCR, or acid-fast bacilli, AFB staining in biopsy samples. History. Patients may have risk factors for TB, e.g. exposure, travel to endemic areas, and present with systemic symptoms like night sweats and weight loss, which are less common in sarcoidosis. Fungal infections. Histoplasmosis and coccidioidomycosis both may mimic sarcoidosis with pulmonary infiltrates and mediastinal lymphadenopathy. Differences. Granulomas in fungal infections can also show caseating necrosis. Fungal cultures, antigen testing, and specific antibodies, serologic tests, help differentiate these infections. Geographic history is important, e.g. histoplasmosis in the Ohio and Mississippi River valleys, coccidioidomycosis in the southwestern U.S. Leprosy, similarities, can cause granulomas in skin and nerves. Differences. Leprosy has characteristic cutaneous lesions with acid-fast bacilli present on biopsy. Berylliosis, chronic beryllium disease. Similarities. Berylliosis presents with granulomatous inflammation in the lungs, similar to sarcoidosis. Differences. History of exposure to beryllium in industries like aerospace, electronics, or manufacturing. Beryllium lymphocyte proliferation test, BLPT, is diagnostic and helps distinguish it from sarcoidosis. 2. Autoimmune and inflammatory diseases. Hypersensitivity pneumonitis, HP. Similarities. Both conditions may show lung infiltrates and granulomas. Differences. HP is associated with exposure to organic dusts, such as bird droppings, molds, or certain chemicals. The distribution of infiltrates in HP tends to be more upper lobe predominant and diffuse, whereas sarcoidosis commonly affects the middle and upper lobes with a more nodular pattern. Histologically, HP shows loosely formed granulomas with interstitial inflammation, in contrast to the tightly packed, well-formed granulomas of sarcoidosis. Granulomatosis with polyangiitis, GPA, formerly Wegener's granulomatosis. Similarities. Both diseases can cause lung nodules, granulomas, and systemic symptoms, e.g. fatigue, fever. Differences. Histology. GPA granulomas may show necrosis and vasculitis, inflammation of blood vessels. Anti-neutrophil cytoplasmic antibodies, ANCA, GPA is associated with CNCA positivity. Other features. GPA often affects the kidneys, glomerulonephritis, and upper airways, sinusitis, nasal ulcerations, which are less common in sarcoidosis. Chronic granulomatous disease, CGD. Similarities. CGD can present with recurrent infections and granulomas in the lungs, skin, and lymph nodes. Differences. CGD is a genetic disorder that impairs phagocyte function, leading to recurrent bacterial and fungal infections, often starting in childhood. A nitroblue tetrazolium test, NBT, or dihydrorhodamine 123, DHR test, can diagnose CGD. 3. Malignancies. Lymphoma. Similarities. Sarcoidosis can mimic lymphoma, with both conditions presenting with lymphadenopathy, systemic symptoms, and organ involvement, e.g. lungs, liver, spleen. Differences. Lymphoma shows atypical lymphoid cells, whereas sarcoidosis shows non-caseating granulomas. PET scans. Both conditions can show high uptake on PET imaging, but biopsy remains essential to confirm lymphoma. Systemic B symptoms, fever, weight loss, night sweats, are more common in lymphoma. Bronchogenic carcinoma. Similarities. Pulmonary nodules and mediastinal lymphadenopathy can be seen in both sarcoidosis and lung cancer. Differences. Biopsy of nodules or lymph nodes will reveal malignant cells in carcinoma. Smoking history. More common in lung cancer patients. Castleman disease. Similarities. This rare lymphoproliferative disorder can present with lymphadenopathy and systemic symptoms. Differences. Histologically, Castleman disease shows a characteristic pattern of lymphoid proliferation, not granulomas. 4. Other granulomatous conditions. Primary biliary cirrhosis, PBC. Similarities. Both sarcoidosis and PBC can cause granulomas in the liver. Differences. PBC is associated with antimitochondrial antibodies, AMA. PBC often presents with cholestatic liver disease and pruritus. Crohn's disease. Similarities. Granulomas can form in the intestines in both Crohn's disease and sarcoidosis. Differences. Crohn's disease typically involves the gastrointestinal tract with symptoms such as abdominal pain, diarrhea, and weight loss. Endoscopy and biopsy of the GI tract are diagnostic. 5. Environmental and occupational exposures. Silicosis. Similarities. Both silicosis and sarcoidosis can show lung nodules and granulomas on imaging. Differences. Silicosis is caused by inhalation of silica dust, usually in industries like mining or construction. It often shows eggshell calcification of the lymph nodes on chest X-ray, which is rare in sarcoidosis. Talc granulomatosis. Similarities. Both can cause granulomas in the lungs. Differences. Talc granulomatosis results from inhalation or injection of talc, typically in individuals with substance abuse. Heparin 6. Vasculitis-associated granulomatous diseases. Churg-Strauss syndrome. Eosinophilic granulomatosis with polyangiitis, EGPA. Similarities. Both can involve the lungs and show granulomas. Differences. EGPA is characterized by eosinophilia and asthma, with peripheral blood eosinophilia being a hallmark. Biopsy shows granulomas with eosinophilic infiltration. Summary of key diagnostic differences. Histopathology. Sarcoidosis shows non-caseating granulomas. TB and fungal infections show caseating granulomas. Lymphoma and malignancies will show atypical or malignant cells. Vasculitis disorders may show necrosis and vascular inflammation. Microbiological and serological tests. TB, positive cultures, AFB staining. Fungal infections, positive cultures, antigen or antibody tests. ANCA, positive in GPA. Serum ACE, often elevated in sarcoidosis, though nonspecific. Clinical history. Exposure history, important for TB, fungal infections, berylliosis, and hypersensitivity pneumonitis. Systemic symptoms. Night sweats, fever, and weight loss are more common in infections and malignancies. Correct diagnosis often requires a combination of clinical history, imagopsy, and specific tests to rule out other granulomatous and inflammatory conditions. No, Castleman disease is not a subtype of sarcoidosis. Although both conditions can present with lymphadenopathy and systemic symptoms, they are distinct diseases with different underlying pathologies. Key differences. 1. Castleman disease. It is a lymphoproliferative disorder characterized by the overgrowth of lymphoid tissue. There are two main types of Castleman disease. Unicentric Castleman disease, UCD, affects a single group of lymph nodes. Multicentric Castleman disease, MCD, involves multiple groups of lymph nodes and can be associated with HHV8 infection or HIV. Histopathology shows a characteristic onion skin pattern of lymph node follicles and hyperplasia of the germinal centers. Treatment often includes surgical removal for UCD and immunosuppressive therapy or anti-IL-6 therapy, e.g. siltuximab for MCD. 2. Sarcoidosis. It is an inflammatory disease characterized by the formation of non-caseating granulomas in multiple organs, most commonly the lungs, skin, and lymph nodes. The exact cause of sarcoidosis is unknown, though it may be related to an abnormal immune response. Histopathology shows tightly packed non-caseating granulomas without the lymph node changes seen in Castleman disease. Treatment involves corticosteroids and immunosuppressive agents. Conclusion. While both Castleman disease and sarcoidosis can involve lymph nodes, they are fundamentally different diseases. Sarcoidosis is an inflammatory granulomatous disease, whereas Castleman disease is a lymphoproliferative disorder. They are not related as subtypes of each other. Sarcoidosis is a complex, multi-system disease with different clinical presentations depending on the organs involved. It does not have distinct subtypes in the formal sense, but it can be categorized based on the organ system involvement and specific clinical syndromes. Below are the key forms or patterns of sarcoidosis often referred to as subtypes based on clinical and organ involvement. 1. Pulmonary sarcoidosis, most common. Prevalence affects around 90% of sarcoidosis patients. Features: bilateral hilar lymphadenopathy, interstitial lung disease, pulmonary nodules, and in advanced cases, pulmonary fibrosis. Symptoms include cough, dyspnea, shortness of breath, chest pain, and wheezing. Staging, scatting criteria: Stage 0, normal chest X-ray. Stage 1, bilateral hilar lymphadenopathy. Stage 2, BHL with pulmonary infiltrates. Stage 3, pulmonary infiltrates without BHL. Stage 4, pulmonary fibrosis. 2. Cutaneous sarcoidosis, prevalence, present in approximately 25% of patients. Features: skin involvement, often in the form of plaques, nodules, or maculopapular eruptions. Specific skin manifestations: lupus pernio, chronic, violaceous plaques on the nose, cheeks, and ears. Erythema nodosum, tender, red nodules, often on the legs, associated with acute sarcoidosis. Skin biopsy shows non-caseating granulomas. 3. Ocular sarcoidosis, prevalence, affects up to 30% of patients. Features: uveitis, inflammation of the uvea, including the iris, ciliary body, and choroid, is the most common manifestation. Can also cause conjunctivitis, keratoconjunctivitis sicca, dry eyes, or optic nerve involvement. Chronic untreated ocular involvement can lead to blindness. Number 4. Cardiac sarcoidosis. Prevalence, present in around 5% of patients, though subclinical involvement may be higher. Features: granulomas in the heart can cause arrhythmias, heart block, cardiomyopathy, heart failure, or sudden cardiac death. Symptoms include palpitations, syncope, fainting, and chest pain. Diagnosed using cardiac MRI or PET scans, biopsy may be required in some cases. 5. Neurosarcoidosis, prevalence, seen in 5 to 10% of patients. Features can affect any part of the central or peripheral nervous system. Common presentations include cranial nerve palsies, especially facial nerve palsy, aseptic meningitis, seizures, or myelopathy, spinal cord involvement. MRI of the brain's spine may show meningeal enhancement or granulomas. Number 6. Musculoskeletal sarcoidosis. Prevalence involves about 5 to 15% of patients. Features: arthritis typically involves large joints, knees, ankles. In acute sarcoidosis, polyarthritis may occur. Myopathy, chronic muscle inflammation leading to weakness or myalgia. Muscle biopsy may show granulomas. Bone lesions. Rarely, sarcoidosis can cause osteolytic or cystic lesions in bones, e.g., hands and feet. 7. Hepatic sarcoidosis, prevalence, found in up to 70% of cases, though often asymptomatic. Features: liver involvement may be detected via abnormal liver function tests, LFTs, hepatomegaly, or biopsy findings. Rarely, sarcoidosis can progress to cirrhosis or portal hypertension. 8. Renal sarcoidosis. Prevalence, rare but potentially serious. Features: granulomas in the kidneys can cause nephritis or granulomatous interstitial nephritis. More commonly, hypercalcemia and hypercalciuria caused by increased vitamin D production by granulomas can lead to nephrolithiasis, kidney stones, or kidney failure. 9. Lofgren's syndrome, acute sarcoidosis. Prevalence, more common in Caucasian patients, especially of Scandinavian descent. Features: a form of acute sarcoidosis characterized by erythema nodosum, bilateral hilar lymphadenopathy, fever, and polyarthritis. Has a relatively benign course and often resolves spontaneously. 10. Hereford-Waldenstrom syndrome, uveoparotid fever. Prevalence, rare variant of sarcoidosis. Features: characterized by uveitis, parotid gland enlargement, fever, and often facial nerve palsy. It is a specific clinical presentation of sarcoidosis involving the eyes and salivary glands. Other organs affected: spleen and bone marrow. Sarcoidosis can involve the spleen and bone marrow, leading to splenomegaly, pancytopenia, low blood counts, and other hematologic abnormalities. Gastrointestinal sarcoidosis, rare but can affect any part of the GI tract, especially the stomach, presenting with dyspepsia or abdominal pain. Conclusion: sarcoidosis can manifest in various forms depending on the organs involved. It is important to recognize that sarcoidosis can present differently in each patient, ranging from asymptomatic cases to severe multisystem disease. Each subtype is essentially defined by the specific organ systems affected, leading to a wide range of clinical presentations and management approaches. Lofgren's syndrome is a well-defined acute form of sarcoidosis characterized by a triad of symptoms: bilateral hilar lymphadenopathy, BHL, erythema nodosum, and arthritis or arthralgia, often affecting the ankles. It is typically considered a benign form of sarcoidosis with a favorable prognosis and a high rate of spontaneous remission. Key features of Lofgren's syndrome: 1. Bilateral hilar lymphadenopathy, BHL. Definition: enlargement of the lymph nodes located in the hilum of the lungs, the area where the bronchi, blood vessels, and nerves enter the lungs. Diagnosis: BHL is typically identified through chest X-ray or CT scan. It is a hallmark of acute sarcoidosis and is often asymptomatic, but can be associated with a dry cough or mild respiratory symptoms. 2. Erythema nodosum. Definition: an inflammatory condition characterized by the presence of tender, red nodules or lumps under the skin, typically located on the shins. Clinical presentation: appears as symmetrical, painful red nodules that are usually located on the anterior surface of the lower legs. It represents a form of paniculitis, inflammation of the fat layer beneath the skin, and is a common manifestation in Lofgren's syndrome. Often associated with systemic symptoms such as fever and malaise, the presence of erythema nodosum in Lofgren's syndrome is considered a good prognostic marker, as it is associated with spontaneous resolution of the disease. 3. Arthritis or arthralgia, joint involvement. The arthritis in Lofgren syndrome is typically acute and mainly affects the ankles, although other large joints like the knees and wrists can also be involved. Symptoms: pain, swelling, and sometimes redness in the affected joints. Symmetrical ankle arthritis is the most common joint manifestation. Patients often experience significant discomfort, and joint symptoms may persist for several weeks to months. 4. Systemic symptoms. Fever, fatigue, and malaise are common systemic manifestations in Lofgren syndrome. Acute onset. Lofgren syndrome usually has a rapid and acute onset, differentiating it from other more chronic forms of sarcoidosis. Diagnostic features. Lofgren syndrome is typically diagnosed based on the clinical presentation and imaging findings. A biopsy is often not required unless the diagnosis is unclear. 1. Imaging, chest X-ray, or CT scan. These reveal bilateral hilar lymphadenopathy, BHL, which is a key diagnostic feature. 2. Laboratory tests. Serum angiotensin converting enzyme, ACE, may be elevated in sarcoidosis but is not specific for Lofgren syndrome. Inflammatory markers. C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, may be elevated due to systemic inflammation. Calcium levels. Hypercalcemia may be seen due to increased production of active vitamin D by sarcoid granulomas, but this is less common in Lofgren syndrome compared to other forms of sarcoidosis. Prognosis. Favorable outcome. Lofgren syndrome has an excellent prognosis. In the majority of cases, symptoms resolve spontaneously within 6 months to 2 years. Spontaneous remission. Most patients experience complete remission without long-term complications. Recurrence. It is rare for Lofgren syndrome to recur or progress to chronic sarcoidosis. Treatment. Lofgren syndrome often resolves spontaneously, so treatment is primarily aimed at symptom relief. 1. NSAIDs, nonsteroidal anti-inflammatory drugs, first-line therapy to manage joint pain and inflammation. These drugs are particularly effective in treating arthritis and erythema nodosum. 2. Corticosteroids. Corticosteroids, like prednisone, may be used if symptoms are severe or do not respond to NSAIDs, particularly if there is significant joint pain or other systemic involvement. However, since Lofgren syndrome often resolves spontaneously, the use of corticosteroids is typically limited to cases where symptomatic relief is urgently needed. 3. Colchicine, or hydroxychloroquine. These drugs can be used for patients with persistent symptoms of erythema nodosum or arthritis, especially if corticosteroids are not an option. Epidemiology. Demographics. Lofgren syndrome is more common in certain populations, particularly in Northern European countries like Sweden, Finland, and Ireland. Gender. It has a slight female predominance. Age. Most commonly affects young adults between the ages of 20 and 40 years. Differential diagnosis. Lofgren syndrome must be differentiated from other causes of erythema nodosum and arthritis, such as infectious diseases, e.g. streptococcal infections, tuberculosis, inflammatory conditions, e.g. inflammatory bowel disease, rheumatoid arthritis, drug reactions. Certain medications can cause erythema nodosum. Other systemic diseases, e.g. Behçet's disease, systemic lupus erythematosus. Conclusion. Lofgren syndrome is a specific acute presentation of sarcoidosis that often resolves spontaneously. It is distinguished by the combination of bilateral hilar lymphadenopathy, erythema nodosum, and arthritis, usually affecting the ankles. The prognosis is excellent, with most patients experiencing full recovery without long-term complications.